Dr. Ward Donovan. I'm Chief of Medical Toxicology at Pinnacle Health System in Harrisburg, Pennsylvania. And my practice involves treating individuals who've been poisoned, but most of them are drug overdoses, alcohol intoxication, and particularly I see opiate intoxication, opiate overdoses that come to us in two forms. One are younger people who are recreationally abusing opiates such as heroin, but also to a great extent prescription drugs, Percocet, Vicodin. And they're getting these from their parents, they're buying them on the street, they're stealing them from medicine cabinets, they're even stealing them from pharmacies, they're purchasing them, obtaining them wherever they can locate them, forging prescriptions. And the other group of people that we see are those who have chronic pain disorders and really have become addicted due to the fault of their physicians, who prescribe just ever increasing amounts of opiates. And opiates are referred to often as narcotics, things like oxycodone and hydrocodone, for pain relief. And they get to the point where they're just constantly in a narcotized state. That means they're in an opiate overdose state. Their mental status is altered, they're confused, their respiratory status may be compromised, and ultimately they end up at our center under our treatment to try to, first of all, resuscitate them, improve and recover the organ damage that has occurred, which often involves most of their organs, and then we try to get them into counseling. The part that I do, the medical resuscitation part and recovery part, if they present to us alive, is actually the easy part. The hard part is dealing with the emotions and the addiction and the psychiatric issues that have led to their addiction in the first place. And that includes both the younger set who are abusing opiates recreationally, as well as the wide range of ages of people who become addicted to opiates, strong pain relievers, because of some initially usually relatively minor injury that is treated too heavily with opiates, and then they become an addict long after the pain of the injury has resolved, and yet they still are seeking the opiates because now they've become addicted to them. And the growth of this epidemic, and it certainly is an epidemic, at least in our experience, and according to reports such as from the Center for Disease Control, really began in the early to mid 2000s, in the 2005 range in particular. And it has just expanded ever since. And I and my group of medical toxicologists devote our time to treating these individuals. But unfortunately, as I said, our treatment is just the beginning. And the difficult part is to get them into recovery and long-term recovery. And unfortunately, I experienced the addiction to opiates in my own family, in my son. My son had attention deficit disorder with anxiety and depression, and that led to him seeking relief in the form of initially alcohol, then marijuana, and finally opiates and cocaine, and just about any drug he could find. And we had him in counseling from the time he was in his mid-teens until he finally died of a drug overdose at age 28. And the addiction led him into the court system, the legal system, unfortunately, because the legal system does not treat these individuals. It punishes them, does not provide any meaningful rehabilitation and counseling when they're incarcerated. They're simply punished, let out. The stress of being in jail adds to their emotional disorders or psychiatric disorders and leads them back into addiction again. And it's a vicious cycle. My son's problems with the legal system began just with driving under the influence, and that's his only crimes against society. And yet he spent between about age 20 and age 28 a total of over 3 years in and out of either prison or work release programs, simply because he had 2 different DUIs, because he continued to fail drug tests, because he would begin using drugs again after he got out of jail or work release. And so it was a constant vicious circle of in and out of jail, in and out of drug rehabilitation programs, but never an effective one. The epidemic of opiates, I relate personally to a similar situation in the 1790s. We own a home that was built in 1790. My family and my son grew up in that home, or at least starting when he was about 8 years old, lived in that home. And in the 1790s, the gentleman who was a Revolutionary War soldier who built this home lost his daughter to scarlet fever in about 1795. Scarlet fever came out of Philadelphia and spread west to the central Pennsylvania area. And that epidemic killed hundreds, if not thousands, of children. And now we have a similar epidemic. That little girl who was about age 5 and died of scarlet fever in my home now is similar to the situation I faced, where my son died in that same home, but from a new epidemic, the epidemic of opiate abuse.
Back to the amount of people that you treat here that have what we call non-fatal overdoses. I don't know if you're aware that Pennsylvania hasn't cooperated with SAMHSA since 2009, so the statistics that occur in Pennsylvania never go to the federal government. And I've been trying to find out, there must be, according to their statistics, there is a ratio of fatal overdoses to non-fatal overdoses. In this area of Dauphin County, have you ever looked at the amount of fatal overdoses versus non-fatal overdoses?
No, that would require comparing my statistics with the coroner's statistics, and you'd have to not just look at the Dauphin County coroner, but the other surrounding county coroners as well. So I know how many people we treat from opiate overdoses, and it's several a week who come in either acutely overdosed or just suffering some of the more lingering effects of chronic addiction. But no, I don't know. I don't know how the survival is. I would certainly say that we see the tip of the iceberg, that most of the people suffering from overdoses either are fortunate enough to survive and never present to a hospital, an emergency room, any emergency room in the area. Many of them, but I don't know the numbers, die. And so we just see a few who are fortunate enough to be found, or a family member usually bring them in, and we're able to resuscitate them, but not always successfully. Some of them succumb eventually, maybe within a few hours of presenting to us, or maybe a day or two later. Some of them recover all of their organs except one, their brain. They suffer from what's called hypoxic brain injury, and what's often referred to as they become in a vegetative state. And they end up in a long-term care facility and ultimately die of infection or other complications of being in a prolonged coma.
You're not seeing the hepatitis C and the other complications as a result of this, or what are you?
Oh, many of the people we see have hepatitis, but if their sole problem for presentation to the hospital is hepatitis, then they would go to a different group of physicians, would not come to our toxicology service, or would not be seen by the medical toxicologists. But yes, certainly a significant number of our patients have developed hepatitis from their intravenous use of needles in particular.
So essentially, you're treating those that strictly come in here as a result of, most of them I would assume are unconscious. Do they have more than a 24-hour stay, or what's the average stay for most?
That widely varies. Those who take a single overdose of heroin can actually be observed in the emergency department for a few hours, get a dose or two of Narcan, also known as naloxone, and actually go home if they've suffered some, or hopefully go to adequate counseling, but that's up to the individual, and all too often they choose not to seek counseling. Some of them have enough organ injuries, such as damage to their kidneys, damage to their lungs, sometimes damage to their heart, that they need to be hospitalized. And those that are hospitalized generally stay 2 to 3 days, although those with more major organ injury may be admitted to us for anywhere from 1 to 4 weeks. And then they get to a point where either they're fully recovered or we transfer them to some sort of a long-term care facility.
Do you see any, you probably don't have enough time to get emotionally involved with these people's lives, or maybe you do, but do you see any common characteristics?
Absolutely. One very common characteristic that I'm sensitive to is the relationship between attention deficit disorder in young people and the abuse of drugs. I can usually recognize almost immediately a young person who has abused drugs, and recognize that they've had attention deficit disorder that may or may not have ever been diagnosed. The parents may be aware of it, and the young person may have been under treatment for years, as my son was, or they may never really realize that the instigating factor, the distressing factor that's led to drug abuse in that young person is attention deficit disorder.
What, in your opinion, is causing this epidemic rise in ADHD?
I think it's always been there. It's a matter of what their drug of abuse is. I think it used to be alcohol. I know it used to be alcohol. Now, with more ready availability of the opiates, either prescription opiates or street heroin, they're turning to those more powerful drugs. One of the factors that has led to this opiate epidemic is the well-intentioned efforts of medicine to control pain. And pain became what's called the fifth vital sign. How much pain do you have? Because you shouldn't have any. And if you have any pain at all, well, let's throw some opiates at you, and then in increasing amounts. And so either those people get addicted, or they take those prescription opiates home, and those prescription opiates then are available to their family, usually their children, sometimes to other relatives or friends even, who are in the home, and steal these from the home, from the medicine cabinet. The more increasing availability of heroin, and particularly the decrease in the cost of heroin, has made its use epidemic. And those who initially start out using prescription drugs, and perhaps again stealing them from their parents from medicine cabinet, or procuring them on the street, find that they can no longer afford those, because one tablet of Vicodin might cost anywhere from $10 to $40 on the street, whereas a bag of heroin might only cost $3 to $5. And more typically, those prescription tablets, are going to sell for $20 or $40 per tablet, and not have as long-lasting effect as 1 or 2 bags of heroin that they can purchase for a few dollars.
If we were to take narcotics, prescription narcotics, out of the picture, which seems like an impossibility, do you feel that would have any impact about the underlying causes of what's causing this addiction to begin with?
I don't think that the underlying causes would go away, but the availability would go away, or at least be reduced. It's never going to go away. If we weren't prescribing, and by we I mean the medical profession, weren't prescribing so much opiates, then I think we certainly would see fewer victims of prescription opiate misuse. And there are actions being taken in this state and other states as well as federally to reduce the availability of some of these prescription opiates. For example, restrictions on the number of opiates that you can prescribe out of an emergency room, so that people can't jump from one emergency room to another, get a prescription at one place, go to another hospital, get a prescription at another place. They can only get a few tablets at each place. And now, soon, there will be a program in place in Pennsylvania where physicians will be able to access a database that will allow them to know whether the individual they're treating in their office or the emergency room or in the hospital is what's called a doctor shopper, someone who's going to various places and obtaining opiate prescriptions, so that they will be attuned to the fact and recognize the fact that that individual is addicted to drugs, and try to get them some counseling, and certainly try to wean them off the opiates that they're using, and treat their pain, if they do indeed have true pain, with some other means and other medications and reduced doses of the opiates, along with other non-medicine therapies to reduce pain, and adjunctive treatments, adjunctive medications that aren't as potent or as dangerous as the opiates, such as Neurontin and pregabalin and similar drugs. But reducing the availability is not going to make the desire to abuse drugs go away. That's a greater effort, and that's an effort that I'm not involved in. And as I've said before, that's a much higher hill to climb, huge mountain to climb, as compared to what I do, which is just simply to recover that individual if they've survived the overdose, get their organ functions back to normal, and then try to get them into a rehabilitation program. But you can't force someone to do that. Unlike the depressed person who may try to commit suicide in a single event, the opiate abuser is slowly killing themselves, but there's no legal means to control that. Unlike there is a legal means to control suicide attempts, that individual can be committed against their will to a psychiatric institution, but the addict can't be. If they choose to continue to use drugs, there's little that can be done. Some other advances that have occurred, and one that I think is very effective, and data has shown it to be effective, are the drug courts. And the drug courts came into place too late for my son. Tragically, a drug court was established about a year after my son died, and he would have been a perfect candidate for drug courts. And drug courts, at least in statistics I've read, have had a much higher success rate than counseling and traditional rehabilitation programs. And these drug courts are very strict. They require almost daily appearance before a judge or a magistrate or some legal authority to monitor their progress, test them for use of drugs, with a powerful weapon to be used if they fail the drug court, and that is then they go to a standard prison. So it keeps them out of prison, which does nothing but punish them and offers no help whatsoever in their addiction, and gets them into intensive rehabilitation programs. Another program that has just been developed in Pennsylvania, the law just recently passed, is the availability of naloxone or Narcan, which is the antidote for opiates. But that's going to save a small number of people, I think. The larger number of people need to be saved by much more complicated and much more long-term and much more expensive.
In the case of your son, more specifically, what age was it when you believe he might have started down that drug road?
Treating the surface, which is give them a dose of naloxone and make them recover that time, but then a week later they take another overdose. This time nobody's around with that naloxone or Narcan, and they're found dead eventually by someone. Well, we believe he started in his early to mid-teens with alcohol and marijuana. It became quite obvious, certainly by his high school years, that he was abusing drugs and alcohol. But he probably started as early as age 12 or 13. We saw a change in his behavior about that age, about age 13. And he had very low self-esteem and depression and anxiety because his attention deficit disorder prevented him from doing well in school, interacting well with his friends in school and his classmates, and he became so stressed and depressed about that he found that he could self-medicate with medications, and attempts to treat his attention deficit disorder with traditional drugs such as Ritalin were not successful, and he would refuse to take them, and found much more relief from street drugs and alcohol and marijuana than he did from any medication that his psychiatrist could prescribe for him.
Do you think that ADHD, like autism, which is also being found at such great rates, in your opinion, is that a genetic disposition, or is that something?
Yeah, I think there's no question that ADHD is genetic, and it's not something that you acquire from your environment. It's genetic, and it does run in families, along and usually associated with depression and or anxiety. So I'm focusing on the ADHD because that's what started my son down his eventually fatal road. But there are many other factors that can lead to that as well, whether it's abuse as a child, molestation as a child, disrupted homes, lack of family support. There are many factors that lead young people into the abuse of drugs. Very often alcohol or marijuana are the gateway agents, but then they lead to more powerful drugs later on.
Can't ADHD also be triggered by trauma in childhood as well?
I think there's some research that shows that, but I'm not an expert in the origins of ADHD. I'm more experienced in both within my family, my son, as well as seeing the individuals that I treat, and many of them have ADHD, and recognizing an ADHD young person. And ADHD doesn't really, like addiction, ever be cured. You have it for your whole life if you have it, but most people tend to learn to channel it, use it somewhat to their advantage. Others, unfortunately, can't control it, and it's so severe that they just turn to an abuse of drugs for the rest of their life, for as long as they might survive.
What is the average survival rate that you've seen in the age group that comes in? Or is it,
Well,
is it all over the board?
I don't know the average years of drug use that eventually leads to death, but I can only tell you that the age group that we see is anywhere from early teens to age 45 to 50, with most of them being in the age group of about 18 to 30.
Is there any difference between females versus males?
Oh, we see a preponderance of males, but that's not to say that we don't see females. We see a significant minority of our patients are females. And I should add that this addiction and this epidemic of opiates crosses all ethnic groups, crosses all age groups, even though it tends to be more of a younger person's problem. So no matter what their religion or their race or where they live or how affluent or non-affluent their family is, this epidemic crosses all those boundaries. In Harrisburg, we are located, Harrisburg Hospital is located in an urban area, but the majority of the patients that I see actually come from the suburbs and the rural areas surrounding Harrisburg, rather than downtown Harrisburg itself.
Interesting. Once they get hooked, there's obviously a chemical change in the brain as well that takes place, and from what I've seen, it happens within several weeks. And some of these drugs cause brain damage within that same period of time. Can you elaborate on that whole process?
Well, first, some of the origins of drug addiction relate to what are called neurotransmitters, chemicals that send messages to the brain, such as serotonin and dopamine. And so many people who become addicted already have a disruption of their serotonin mechanisms or dopamine mechanisms, and that leads to anxiety, depression. But also, as you use these drugs, those chemical transmitters systems are altered, and they lead to a progression of their addiction. As the serotonin mechanism, dopamine mechanisms are altered, their addiction or craving is increasing.
Is the medical, government law enforcement, and rehab centers, are they doing what they should be or what they could be doing to treat this?
Well, certainly law enforcement is not. And the legal system is not, except for, as I mentioned, the drug courts. Most of the legal system is oriented towards punishing the addict rather than treating them. Here in Dauphin County, we were fortunate enough, my family, to be in contact with some judges who were not in the punishment mode and focused on the rehabilitation mode, and would send my son, and I see them sending other people, to rehabilitation programs rather than to jail. But some other judges are not as enlightened. But as I said before, the drug courts is a big advancement. As far as the rehab programs, the problem with rehab programs to a great deal goes back to insurance, or the lack thereof. And if you do have insurance to cover rehabilitation, it's usually limited. And so even though addiction is a disease, it's treated differently than diabetes, for example. There's no limit on how many days you might have to spend in the hospital, or how many doctor visits you might have to have, or how much medication you might have to have if you have diabetes.
And that can be brought on by obesity, which is another addiction.
Right. And obesity leads to heart attacks, and heart disease. And again, there's no limitation by insurance companies on how much treatment and how frequently you can be hospitalized. Those limitations are not placed on those diseases. But the disease of drug addiction is treated very differently. And even though there are now laws that are supposed to remove these restrictions on how much treatment an addict can get, the insurance companies seem to be ignoring them and continue to restrict the amount of treatment that in a single year an addict can receive.
What is the average that a person typically can go?
Well, the average stay in a rehab center is usually about 2 weeks. The maximum is 28 days. And that just is the beginning. Now, if that inpatient stay is followed by an intensive outpatient stay, the success rate is higher. But the highest success comes with intensive programs, almost daily treatment for a year or two. That kind of approach in dealing with not just their drug addiction, but the underlying factors in many cases that have led to that drug addiction.
Most of mainstream believes this is primarily an urban problem.
Well, as I said, my son lived in a rural area. We're surrounded by farms. Most of the people that I treat, even though our hospital is located in an urban area, most of them come from the suburbs and from the rural areas. Some of the worst centers for heroin availability and prescription drug misuse are some of the smaller rural towns in central Pennsylvania.
Are you seeing a lot of crystal meth and crack as well?
Oh, we see some, but not nearly as much as we do the opiates because of their availability. And those who use cocaine and use crystal meth, methamphetamines, and hallucinogens are less likely to end up in the hospital because they're less likely to cause respiratory arrest, that is, loss of breathing, which is ordinarily the ultimate cause of death in the opiate overdose. So we're less likely to see them, but we do see a growing number periodically of certain drugs that will come into the area, and they might be in the area for a month or two and then they disappear. Bath salts, for example, and some of the various newer forms of methamphetamine, some of the synthetic methamphetamines. And they seem to come in groups, in bunches, and be available for a while and then disappear. For a period of time, about 3 years ago, we were seeing a serious bath salt case almost daily. And now we rarely see one because there are now laws that heavily restrict the availability of these drugs called bath salts.
In the case of ADHD, one of the things that I've found is that a lot of kids out there are abusing that medicine, meaning that they will fake the symptoms and they will chew it to get that high, and most particularly in females in college ages where they want to lose weight.
The drugs such as Adderall in particular, which is an amphetamine, is not a rare cause for presentation to a hospital and to our service. And as you said, it is typically more in the high schools. We don't see it quite as much in the colleges, where I think they graduate even more potent drugs. But the high school and college group do certainly abuse the prescription drugs that are used for ADHD, and they pass them around to their friends and sell them to their friends and share them at parties. So that's another problem separate from the opiate addiction problem.
And the latest trend I've heard from psychiatrists is they're now putting their, besides chewing them, then they'll start snoring them and then they shoot them up, or the latest fad is to put them in their eyes.
They can use the amphetamines just about by any route. The more dangerous routes are either intravenous or actually snorting. Either one is much more dangerous than just taking it as a pill. That's where we see the very severe cases where they've snorted them. That is, taking them up the nose or injecting these drugs, melting them down and injecting them intravenously rather than taking them orally. But most of the young people we see, particularly the high school kids, are just ingesting them. And that's a group where we are less likely to have them present to the hospital. They may just have some effects that aren't serious enough that they end up being recognized as being seriously ill, and they don't come to the hospital.
It just seems to me that if we target the drug, we're not really, something else will replace it, guaranteed.
It's not viewed as being that kind of down and out inner city drug addict. The same connotations aren't there when you're able to use a drug by a means other than intravenous. Not to say that kids in the suburbs don't use drugs intravenously, but most of them don't. They use them by other means, and they see that as more acceptable, almost as acceptable as drinking alcohol.
Your opinion on pot, marijuana?
I think that in those who have a tendency to addiction, it leads them to other drugs. But I believe that they've got to have a tendency towards addiction, a genetic tendency or an emotional tendency towards addiction, to move beyond marijuana.
The latest research I read shows that a developing brain, 13, 15, 16 years old, using pot on a regular basis creates the same type of brain damage as heroin.
I saw that study. That's a fairly recent study that chronic marijuana use does have damaging effects to the brain. That involves pretty heavy use and not the occasional use. And I think the heavy use occurs in the people who are more prone to have addictive personalities, which probably relate back to psychiatric issues or emotional issues that they suffer.
And some of them even compared puberty to insanity, psychiatrists and so forth. And I think that anything that impairs that development, such as drugs, halts that development.
I think that's pretty well established that drug use impairs growth and development, particularly social development, intellectual development, advancement into a more mature life. The drug addiction holds you back.
Why do most of these kids seem like they're so lost today?
So lost?
Lost.
I think it's the pressures of society, pressures of school, increasing demands and expectations by society, by academia, by their parents. But I think also it relates to the cultural pressures, the peer pressures that they're confused about. You know, do I get into this crowd that's using drugs, or do I try to stay away and lead a more normal life? And it becomes more difficult to lead that old-fashioned normal life now in current society.
There seems to be no individualism. It's like they have to be around each other on a constant basis, either via cell phone or whatever, and the technology there disrupts what I consider to be normal communications, human communications. And in essence, I compare texting to going back to Morse code.
It's a different world than it was 20 years ago technologically. Whether that has a relationship to leading people to drug abuse, I don't know. But one important point to make is that people of all ages, but particularly young people, who use drugs are going to be in a group of other young people who are using drugs. It's a group practice, a group phenomenon. They are rarely doing it by themselves. And so one of the essential treatments of the young person who's addicted is to get them out of that environment, get them away from that social circle, even get them out of that town and into a different area, but some sort of a controlled environment. Because if a person is going to be in a social circle of drug abuse in one town, they move to another town, they're going to find that same circle. But at least temporarily get them away from that social circle they're in and get them to a different area.
It seems like it's a predominant culture, or is a majority, at that age group. And so
Well,
where do you run? Where do you?
As a medical toxicologist, I'm not an expert in the psychiatry of some of these issues and just how predominant it is. I'm not an epidemiologist either, but I can only say that it would be very unusual for me to see a young person who's the victim of drug abuse that I treat and not see that either their family or their social circle or both are involved in the use of drugs as well.
Do you have anything else you'd like
Um, I think what I mostly would want to add is just that parents need to be on the lookout for changes in behavior of their children. And at the first sign of any problems, try to get them help, and serious long-term help. And I've told parents of young people who've had a near-death experience from a drug overdose that they're going down a path of probable death, and that if they have to mortgage their home, take out a loan, whatever they have to do to get them into a long-term rehabilitation program.
Looking back with your son, unfortunately, it's sad to hear these things. If there was anything you would do differently?
Oh, that's something that I dwell on almost daily. I think if I were to do something differently, I would have gotten my son into more long-term intensive programs, although he was in programs as long as 6 months, but they weren't effective programs. I didn't realize it at the time. There are, of course, medical approaches, such as the use of either methadone or Suboxone. I think particularly if I were to do it over again with my son, I would have tried Suboxone. But the results are mixed with Suboxone, and it has to be coupled with intensive counseling, or they're just going to stop taking the Suboxone and go back to the other drug. But those are the things I'd do differently. I'd look at medical treatment combined with extremely intensive long-term counseling.
There is a new drug out in the market that a lot of new addicts have run into. I believe it's Vivitrol or whatever.
Yeah.
It blocks the desire for opiates.
Yeah, it's similar to the idea behind Suboxone. The Suboxone's generic name is buprenorphine. And so any of those agents might be tried. I think personally methadone just prolongs your addiction.
Can it not
Right.
also start another addiction?
And really just you become a methadone addict instead of a heroin addict.
A lot of them I've seen become both.
And and they sell the methadone so that they can buy heroin, and if they can get a hold of methadone other than the very controlled methadone clinic programs. So I'm not a fan of methadone as much as some of the drugs that control the desire and yet don't give you the high, such as Suboxone.
Some of the kids that are going into rehab that use Suboxone and so forth had some very negative reactions to it, like they couldn't sleep, and it doesn't work for everybody.
No, Suboxone is something that I think should be tried, but it's not successful with everybody. The side effects are not great, though, unless they mix taking Suboxone with an opiate, and then they can have an interaction between those two drugs that can make them quite ill. But Suboxone itself is, for most people, is safe. The question is whether it's going to be effective for them.
And as far as heroin is, they can get into rehab. I have a girl I interviewed that found her addiction when she was in jail to heroin.
Drugs are available in prisons. We don't want to kid ourselves about that. And the environment of going to jail also just fosters that culture of drug abuse. So sending these people to jail is certainly not the answer, but it's an approach that the legal system has used for decades, and it doesn't work. If anything, it makes the problem worse for that individual.
Do you get to see up here the violent deaths and murders and attacks that are a result of drug fights and drug abuse going on within the community?
I can speak from my own just observations in the Harrisburg area that we have an extremely prevalent, violent group or groups and violent culture that leads to robbery, murder. The addict might be stealing, might be robbing people to support their habit. They're killing each other over the drugs and drug deals. Harrisburg itself has a very high violent crime rate and very high homicide rate, most of it related to drug abuse.
And unfortunately, there's a lot of kids, babies, being brought up in that environment.
We certainly see in our maternity department infants that are addicted and have to be withdrawn. We have a particularly difficult problem with pregnant women who are addicted, and how to get them safely through their pregnancy and control their addiction during the pregnancy. Unfortunately, they often do deliver drug-addicted infants who also can have congenital abnormalities due to the drug abuse of the mother.
I know in Mercy Hospital down in Baltimore, for example, on a typical given day, they can average out 60% of the babies being born as being addicted. I don't know what that percentage
I couldn't tell you what our data is here at Harrisburg Hospital. I could put a plug in. I don't know if anybody be interested, but a foundation has been established in my son's name through the Medical Toxicologist Society. The American Academy of Medical Toxicology has a foundation under my son's name, the Ward Donovan Fund. And the American College of Medical Toxicology website is available by Google. I can't quote their address or phone number, but if you're interested, this fund is intended to assist research through grants about addiction, the factors that lead to addiction, the best treatment of addiction. So each year we give 1 or 2 grants out of this fund to medical researchers. So again, it's the American College of Medical Toxicology. You can Google their website and find their address, and also you should be able to find on that website the Medical Toxicology Foundation. And you can contribute to that foundation, and specifically, if you're inclined to do so, designate your donation to the Ward Donovan Fund for the treatment and research on drug addiction.
Well, thank you. I appreciate the information. I appreciate you taking your time. I'm sure this is an amazing issue to talk about.
No. I was laying in bed awake last night thinking about, it's been 7.5 years thinking about I should have gotten my son in a Suboxone program. I'm in the process. I'm in the process of recertifying as a Suboxone prescriber. It just brings up those memories that I never got my own son into a Suboxone program, and I wish I'd at least given that a try. Because some addicts, there was a where did I see that? It was a website where I read that Suboxone was being criticized as just another crutch, another addiction, and many addicts tweeted back that Suboxone saved their life. It seems to work for a lot of people, but not for everybody.
There's a lot of bad information out there, a lot of myths such as, if I snort it, I'll get addicted. That if you go into rehab for 2 months, it's a lack of willpower, it's this, it's that.
Oh yeah,
the ignorance is far more greater than the actual knowledge.
I don't know if we're still rolling, but
I can shut this off.
well, no, I was going to say on
go ahead,
camera
go ahead,
that
go ahead.
that there is that misperception that you're not an addict if you're not using the drug intravenously, and that it's socially acceptable. It's much like the idea that, well, I only drink beer, so I'm not an alcoholic. I only use pills that were prescribed by my doctor, so I can't be an opiate addict. It's simply not true.
Or I'm recovered, but I'm still smoking pot and drinking alcohol.
Yes. So there's a lot of rationalizing by the addicts. There's a lot of non-recognition of the problem by family and friends because they're not out on the street shooting up heroin, so it's okay.
I think probably one of the scariest things of all that still predominates is that, you know, they won't get treatment until they hit bottom. Well, to them, bottom is death. I mean, they will go through the most hellish, bizarre lives and still not find bottom.
Most people who die, in my experience, from an opiate overdose have already had one or two near-death experiences preceding it. So they've really already hit bottom, and they still, what you would call hitting bottom, you almost died, you had to go to the hospital, be resuscitated, yet they go back after having that near-death experience to using again. The addiction has such a strong hold on them. Cycle. My son's problems with the legal system began just with driving under the influence, and that's his only crimes against society. And yet he spent between about age 20 and age 28 a total of over 3 years in and out of either prison or work release programs, simply because he had 2 different DUIs, because he continued to fail drug tests, because he would begin using drugs again after he got out of jail or work release. And so it was a constant vicious circle of in and out of jail, in and out of drug rehabilitation programs, but never an effective one. The epidemic of opiates, I relate personally to a similar situation in the 1790s. We own a home that was built in 1790. My family and my son grew up in that home, or at least starting when he was about 8 years old, lived in that home. And in the 1790s, the gentleman who was a Revolutionary War soldier who built this home lost his daughter to scarlet fever in about 1795. Scarlet fever came out of Philadelphia and spread west to the central Pennsylvania area. And they're even stealing them from pharmacies. They're purchasing them, obtaining them wherever they can locate them, forging prescriptions. And the other group of people that we see are those who have chronic pain disorders and really have become addicted due to the fault of their physicians, who prescribe just ever-increasing amounts of opiates. And opiates are referred to often as narcotics, things like oxycodone and hydrocodone, for pain relief. And they get to the point where they're just constantly in a narcotized state. That means they're in an opiate overdose state. Their mental status is altered, they're confused, their respiratory status may be compromised, and ultimately they end up at our center under our treatment to try to, first of all, resuscitate them, improve and recover the organ damage that has occurred, which often involves most of their organs, and then we try to get them into counseling. The part that I do, the medical resuscitation part and recovery part, if they present to us alive, is actually the easy part. The hard part is dealing with the emotions. I'm Dr. Ward Donovan. I'm Chief of Medical Toxicology at Pinnacle Health System in Harrisburg, Pennsylvania. And my practice involves treating individuals who've been poisoned, but most of them are drug overdoses, alcohol intoxication, and particularly I see opiate intoxication, opiate overdoses, that come to us in two forms. One are younger people who are recreationally abusing opiates such as heroin, but also to a great extent prescription drugs, Percocet, Vicodin. And they're getting these from their parents, they're buying them on the street, they're stealing them from medicine cabinets. And the difficult part is to get them into recovery and long-term recovery. And unfortunately, I experienced the addiction to opiates in my own family, in my son. My son had attention deficit disorder with anxiety and depression, and that led to him seeking relief in the form of initially alcohol, then marijuana, and finally opiates and cocaine, and just about any drug he could find. And we had him in counseling from the time he was in his mid-teens until he finally died of a drug overdose at age 28. And the addiction led him into the court system, the legal system, unfortunately, because the legal system does not treat these individuals. It punishes them, does not provide any meaningful rehabilitation and counseling when they're incarcerated. They're simply punished, let out. The stress of being in jail adds to their emotional disorders or psychiatric disorders and leads them back into addiction again. And it's a vicious, and the addiction and the psychiatric issues that have led to their addiction in the first place. And that includes both the younger set who are abusing opiates recreationally, as well as the wide range of ages of people who become addicted to opiates, strong pain relievers, because of some initially usually relatively minor injury that is treated too heavily with opiates, and then they become an addict long after the pain of the injury has resolved, and yet they still are seeking the opiates because now they've become addicted to them. And the growth of this epidemic, and it certainly is an epidemic, at least in our experience, and according to reports such as from the Center for Disease Control, really began in the early to mid 2000s, in the 2005 range in particular. And it has just expanded ever since. And I and my group of medical toxicologists devote our time to treating these individuals. But unfortunately, as I said, our treatment is just the beginning.